Hello, everyone. Welcome. Thank you so much for joining us today, the last session of the Iowa Ideas Conference here at the Healthcare Track. So glad that you've decided to stick with us and join us for this final idea sharing panel. My name is Michaela Ram. I'm a healthcare reporter for the Gazette, and I will also be the moderator for this panel, The Future of Healthcare. Just a couple of housekeeping items before we really get started. These sessions are recorded, so you have the opportunity to go back and view them later if you so wish. We also would like to thank our sponsor, the Cedar Rapids Bank and Trust.
Hi, I'm James Klein, president of Cedar Rapids Bank and Trust, and I challenge all of you to think big. Now that you walk away from this conference, what are you going to do? What are some big ideas that have been percolating in your brain that you want to move forward and hopefully change what we're doing each and every day? Thank you for attending. Share those big ideas, and let's make everywhere a better place.
Great, and that was a great segue to what this panel is all about, which is sharing big ideas. So this panel will be a little bit different than what we've been doing previously throughout the sessions and throughout the panels. This one will be interactive. So you, the attendees, will have the opportunity to talk with us, the moderators and the panelists, as we discuss the future of healthcare and dive into all of the topics that are around that. So I would encourage you guys to use the chat function throughout to either pose our panelists questions, share your own ideas, talk amongst yourselves, and really just kind of interact as we try to carry some of these ideas forward into more actionable steps. You guys will also have the opportunity to unmute yourselves and even join the conversation a little bit if you so choose. So if you have a question you'd like to pose to the panelists, you have a point you'd like to raise, or maybe an idea you'd like to share on kind of some of these issues we're talking about, I'd encourage you to use the raise hand function. You should be able to find that under the participant tab on your Zoom. And we'll call your name and you'll be able to unmute yourself and turn on the camera if you so wish. But like I said, if you prefer not to speak, you're always welcome to pose your question in the chat, and we will be able to either get to them at the end or kind of get to them throughout the conversation as it sort of makes sense for us to talk about it. But to get the ball rolling and to really kind of drive us in our conversations are our three wonderful panelists who will be joining us today. First off, I will introduce Michelle Niermann. She is the President and Chief Executive Officer of UnityPoint Health Cedar Rapids. With us today also is Joe Locke. He is the President and Chief Executive Officer of the Eastern Iowa Health Center, which is the federally qualified health center located in Cedar Rapids. And last but not least is Suresh Gunasekaran, who is the Chief Executive Officer of the University of Iowa Hospitals and Clinics. And he's also the Associated Vice President of the University of Iowa Healthcare. Thank you guys for joining me today.
Thanks for having me.
Thanks, Michelle.
Great.
Michaela.
Well, great. Well, let's just dive right into it. Obviously, the future of healthcare has really, it's an interesting text right now with the pandemic and sort of the ongoing spread of the COVID-19 virus. So, you know, one thing that the pandemic has really highlighted was some vulnerabilities the United States has in its critical resource supply chain and hospitals' emergency response capabilities in some areas. I wanted to pose a question to you. What gaps have been filled in the year and a half that we've been dealing with this pandemic? Or what are gaps that are being filled to address some of these capabilities to prepare for the next emergency response?
I can kick us off. I'll talk just briefly about supply chain and then maybe emergency response, sort of more broadly defined. I think from a supply chain perspective, certainly the pandemic laid bare some soft spots in supply chain early on related to PPE. I think our industry, like virtually all industries, though, is continuing to see, short outs and increased cost of supplies in a variety of categories now. PPE actually, maybe other than the cost piece, is stabilized, some in terms of its availability. So for us, I think, there's a few things that we look to do. We want to understand our suppliers better. We want to know more, about their back of the house and how it is that they stay diversified and are keep up to produce the products that they produce. In some cases, another case, our health system, for example, is paired together with some others from across the country to work on development of certain kinds of pharmaceuticals for ourselves to be less reliant ultimately on other suppliers that might be offshore or have other limiting factors that we're concerned about. So I think it's both a matter of understanding your suppliers and being creative in some cases in how you source, including in some cases maybe starting to make your own. I think from an emergency response perspective more broadly, I know Joe and Suresh will have the same things to say. I mean, we've learned so much, and of course, this part of the state also experienced a natural disaster last year in the form of the derecho. So we got a lot of experience, and I suppose in a good sense, we've learned a great deal about how to scale up and how to be responsive to respiratory illness in particular. We actually did a tabletop drill yesterday, just thinking about various contingencies that could impact staffing going forward. And you just see yourself tapping into over and over again, well, we did this in November, or we did this in March, and really do feel like we've learned a lot, including the importance of being in good communication with partners, with others in the healthcare system. So those are a couple of things that start us off with.
Absolutely.
One of the things that impacted us in the oral health world in terms of our dental capability is with regard to those new PPE standards as well. Just one example is the installation of industrial washing machines and industrial dryers in our dental clinic because of the head-to-toe PPE that's mandated that just simply didn't exist before. So the American Dental Association, the Iowa Dental Association, put forth a mandate. We had to furlough workers for 3 months last year from April through July to prepare adequately for a return to work on July 1. And that's just one example. I mean, the world has changed, and it seems like we had to pivot just like my colleagues here did. Seems like every day sometimes.
I think Joe and Michelle covered a lot of it. I'll take the question a little bit different direction. For me, I think for healthcare, this is a bit of our own 9/11 kind of moment. And I think that there will be certain things like moving forward, how we do our emergency response. How do you respond to the pandemic or the event in and of itself? I think that there's a lot of learning in this that, the university did a lot of COVID care, but to be perfectly honest, everyone here did a lot of COVID care, and how we could do it all better together and more highly coordinated during the actual event. And I think during 9/11, there was a lot of talk afterwards about how emergency response needs to be more coordinated between fire and police and the FBI and other federal agencies. And we almost ended up, as you know, with a Department of Homeland Security. And so I think that there is, that we are going to have to work on, because we couldn't have made it through this pandemic without all of us. No individual entity, no individual organization. All of our wins were community wins, and they couldn't have been done without Joe. They couldn't have been done without Michelle and a whole host of others. And I think we all know that's a reality. So next time, how do we, right out of the gate, come with the full strength of what we do? And then the second piece I would say is that we've always been left with a different regime for airline security. I mean, to this day, there's TSA, and fundamentally it exposed, a gap. And I think that there's probably the one that hasn't been discussed is just our public health infrastructure. Just how do you have accurate information on what's going on in your community, what's going on with the spread of disease, the incidence, the capacity, the constraints in our own community. And I hope that moving forward, that kind of investment that we made in TSA, we will continue to invest in our public health infrastructure, because all of us that are on this panel would have preferred to get more perfect information from a stronger public health infrastructure, because if we had that information, we could coordinate our response better. And so I think it's just, those would be the two things I'd highlight. But otherwise, I just really agree with what the others said.
Absolutely. Maybe to follow up on a point that Michelle brought up was, about responding to two disasters. You mentioned the derecho at the same time the pandemic was happening. What lessons were learned kind of from two different emergency responses at the same time? Anything in particular that you guys carry away from that as you prepare for whatever comes next?
A couple things come to mind. I think that a natural disaster is quite a bit different, than a pandemic. Although, some of the arcs that you go through are similar. Sometimes you don't know fully what might hit you. That was certainly the case of, the derecho. That was rather unexpected. Certainly with the pandemic in the beginning, we didn't know really at all what it was that we would expect. The natural disasters are typically much shorter in length, and while terrible, they're much quicker in terms of how they pass. And historically, I would say, as an industry, we've certainly spent, at least in my part where I live in community healthcare, we've probably spent more time thinking about how to respond to natural disasters than we have to things like COVID-19. So probably in some regards a little better prepared there. They both kinds of disasters, and certainly with them happening at once, take a tremendous toll on your people. COVID impacted so many people, obviously from the illness perspective. Impacted people in varying ways from how they responded to it emotionally. In Cedar Rapids, the derecho impacted everyone in sort of a very tangible, physical way. They lost power, they lost food, they lost their homes, or had significant damage to their homes. So that one was difficult in the sense that literally no one was left unscathed. Fundamentally, though, I guess where I was going with that. For both kinds of circumstances, is that issue of that impact that it has on people and how you try to take care of your people through these circumstances.
Absolutely. I wanted to circle back on something that Suresh brought up about the public health infrastructure and the effectiveness of getting the message out. I had a panel yesterday with public health officials talking about how challenging it was to get the messaging out, or at least cohesive messaging out, because there was just so much information coming from all levels. There was also the way people reacted to the information. We know that there's been a lot of division in the pandemic and just sort of a lot of disagreement about the way we should be responding to the pandemic. And, we've seen that carried on to the COVID-19 vaccine effort. But I wanted to ask our panelists, from a perspective of as a healthcare leadership, how can healthcare better grapple with the politics around healthcare and the politics around pandemic response? I wondered if you had any, lessons learned or maybe opportunities to approach things differently, or if there's a way you can approach that differently.
It's tough. I mean, I would just say that, there's a difference between health system leadership and healthcare leadership. And, we've long learned how to, and we've been mentored as leaders to be leaders of our individual entity. And, many like Michelle and others and Joe, I mean, they have a community aspect to their leadership too, because that's there for me, be part of the university leadership. But this really challenged us as an industry to suddenly be thrust into being public leaders. And the public health infrastructure was both well suited to support us and ill suited to support us. And I think that, it was very, very difficult. And but I want to emphasize there were clear positives, that any time that you have this much societal change, it's going to be hard to have one unified voice. And I think sometimes we beat each other up a little bit too much. I think that we actually made significant progress. I mean, this was a once in a generation pandemic. And I actually think a lot of the communication actually worked very accurately, worked very well. So many Iowans, so many Americans received the healthcare that they needed in a timely manner, in an appropriate setting, and had great results. Our healthcare system certainly suffered a lot of damage, particularly the healthcare workforce that had to work so hard. But in spite of that, the results overall have been really good. And we do talk a lot about the gaps in vaccination and the gaps at times in following safety standards, but we failed to realize a lot of the success that we have had. And that's happened through partnership. But those areas that we failed, I think two things hurt us. One was a lot of our public health infrastructure was under-resourced for an event like this. And so we were expecting too much of an underfunded and overwhelmed infrastructure at times. And so the criticism is valid, but it wasn't fair. We didn't invest 10 years in a row, do community-based drills, and public health was always ready for this and they planned for this, and then we did this. I think we should, treat those individuals with a whole lot of humility because, this was a very generational challenge and it exposed some weaknesses. And then the other piece I would say is that I think there is an opportunity for us to work together better moving forward. And I think one of the things that I would always say is that when you're facing all of this societal change, everyone, including the media, wants an answer immediately. And in these kinds of scientific journeys, the answer is never going to be available immediately. And so how do you handle this gap of, I don't know, how long is this pandemic going to last? Or how effective is a COVID test, or how effective is a vaccine, or how effective is a mask? All of these things were things that it took time to figure out the reality of. And I think a lot of our dissatisfaction was during that time. I think that we were impatient, and during that time, the story changed a lot because we learned as we went. But I would like us to not be too negative about the divisiveness and not be too negative about our lack of consensus. I think over a period of time, over the next couple of years, there will be a consensus around COVID-19. There will be. The science will catch up and the community will catch up. But those are my thoughts.
So Michaela, when Suresh began just a minute ago, he said, this is tough. And it is. The guest article on the opinion page last week in the Gazette that was written by the brother of a man that died because, according to him, news outlets made the man believe that COVID was a hoax and the vaccine was irrelevant. I mean, it's so disheartening. It's also amazing to me when we reached the inflection point a few months ago of finally having more vaccine, more supply than demand. I just couldn't believe it. That all of a sudden we couldn't fill our COVID clinic. And so we all need to do a better job to advocate for vaccines. We can do better.
I think I would just say, to add on to that, since, as part of this conference, we're all thinking about what we can do to help in a variety of areas that are impacting us as islands, impacting society. I was really struck early on when you talk about sources of information. I was struck early on in some of the communication we were doing with our own team members. And as Suresh noted, things changed because, science is evolving, it learns, so it was always challenging, particularly early on, to stay up, to stay in that good open communication. But I remember getting some feedback from one of our housekeepers who said, I read what you give me here because I know what you give me here will be, accurate. It'll be as current as you can provide it to me, and I trust you. And I know if I look at my feed, I'm just going to get upset, and I'm going to get some things that are not, the information that's probably best for me to be basing my decisions on, let alone getting a good night's sleep. So I think one of the things that all of us can do is, when we know those good sources of information, CDC, gold standard, there are others, we can share that information. You can share it personally, and, in your feeds, if if you're an employer, you can share out that information, and it's not political. It's, it's science-based, it's evidence-based, and that's, a unifying factor between health systems, healthcare providers, and health, I think, as Suresh talked about earlier. We unified around that set of information and have had a number of successes as a result of doing so. Absolutely.
Well, I would encourage our participants here to maybe share their ideas that they have for improving the vaccine rate, either through the chat function, or again, raise your hand if you'd kind of like to share your thoughts. And as we kind of let those responses populate, would love to kind of direct that question to Joe. From your perspective, addressing that hesitancy, or whatever reason people maybe aren't comfortable getting that vaccine, what opportunities do you see to try to improve that vaccine rate locally, broadly, from whatever perspective you see?
Well, one thing that is true is that people respond to incentives. And, we've seen that across a number of municipalities across the country, even locally. When Lynn County Public Health, I don't know the exact number, but let's say it was about 200 people that took advantage of $50 gift cards from Hy-Vee. I mean, people respond to incentives. And if that's something that could be more broadly offered, I think that can certainly help. Also, at the start of the pandemic, and when actually not the start of the pandemic, but at the start of when vaccines became available, and we saw people that are loved and revered and respected, including not only political figures but also sports figures, actors, etc., showing them with their sleeves rolled up, and people that they admire being vaccinated. I think that made a difference.
Absolutely. Michelle or Suresh, do you have maybe opportunities you see or new avenues to kind of get more people vaccinated?
I was at an event last evening, and one of the folks who was being recognized, among her list of accomplishments, was coordinating COVID vaccine, probably flu too for that matter, but COVID vaccine with the efforts of a food pantry. So a big part of this is finding people where they are. And I think our various public health departments have done a very fine job of that. Again, limited resources, so it's hard to stretch, as far as perhaps they could. But I think if I were to point to something that's hard for us to overcome as health systems or public health, either one, it's kind of anticipating that people will sometimes come to us, whereas we need to just constantly work to find them. And again, I think there are many examples, public health departments, across this part of the state, across the country, they've done some amazing work. But that's key in my mind.
I also think we need to change the temperature. I mean, I think it's fine to have these opinions and articles where we, show regret of people for not getting vaccinated. But that's also like, doing articles on people who get diabetes or have a heart attack or these things and say they wish that they had had a healthier lifestyle. At a certain point, the assumption sometimes is that the person, we shouldn't tolerate the unvaccinated, as opposed to saying that this is just a journey. We deal with this journey all the time in healthcare where people are hesitant about making lifestyle changes or making healthcare decisions. If we can figure out ways to embrace our sister, embrace our brother in this journey, I think that's the really important part. Factually, the FDA only gave full approval to the Pfizer vaccine in the last 90 days. Only in the last 90 days. Until this point, it was an emergency use authorization. In the face of a pandemic, we highly encourage folks for a vaccine that we had 95% confidence, but it had gone through an accelerated process to get approval. And I think we haven't done enough as an organization here and as a community as a whole to emphasize that now this vaccine from Pfizer, and I think pretty shortly Moderna as well, is going to receive full FDA approval, like every other drug that we will provide in a clinic or every other drug we provide in the hospital, which we provide thousands of them, and the public trusts them and they get over hesitancy. It's not like there aren't folks that come into our hospital or clinic who've heard about a drug and worry about the side effects. So many patients now are concerned about whether they should take an opioid. So many patients are concerned about these things, and we help them get over that hesitancy. And so I think that, figuring out a way down the home stretch to humanize this again and accept the fact that hesitancy is normal. It's okay. And our healthcare system confronts it every day, and it's okay. Works. Just in the last month, we have begun to see some significantly hesitant patients voluntarily come in. And the story would simply say that they didn't lose a loved one. Maybe they read an article, but really, I think they became more informed, became more comfortable in some of these things. And I think that we should not give up on our journey. And I'm glad that Michelle kind of slipped an ad in it in piece. We see it every flu vaccine season. Why isn't flu vaccine 100%? Same thing. And we don't vilify the population that doesn't get the flu vaccine. And I think that we have an opportunity to change the discussion. And I hope we embrace the opportunity to change that discussion. Because I think that a little bit of kindness, a little bit of patience goes a long way in helping people get over their hesitancy.
Absolutely. Absolutely. I think that's a good point, sort of embracing people for whatever questions and concerns they have, because that's normal, rather than villainizing them when it comes to their healthcare. It's a very important topic for people. I don't see any questions in the chat or people raising their hands to chat. So I'll just go ahead and kind of divert a little bit. We talked a little bit about this before the panel started, but just kind of how tired everybody is after a year and a half in this pandemic, and just sort of how tired the workforce is in particular. I know burnout has become more of a concern as things progress. So I wanted to talk to you as leaders of your systems, of your healthcare entities. How do you cope with burnout after dealing with this ultra marathon? What have you done, and what else really needs to be done to help support this workforce and their needs?
I'll jump in, Michaela. I spent a couple of days in Des Moines this week and the state association, and it's true that people are so burned out and tired. And so, one of the things that we've done here locally is to really encourage more consistent communication around work-life balance, about taking care of yourself. And also, we've significantly enhanced our employee assistance program. So now not only can people receive cognitive behavioral therapy, talk therapy, et cetera, but also unlimited child care and elder care referrals, financial consultation, pet care consultation, education referrals and resources, as well as community-based resource referrals, legal resources, and even a mobile app for our staff to put on their phones, and just letting them know that, if you need a little personal break and to try to get your head back in the game, then your manager is going to support that. And so it's about being empathetic and taking care of each other.
I think it's always a good time to have a good culture, so one of the things that I think no doubt important to all of us is that we start from a good, strong foundation, that you are always working to create organizations where you have good communication, where you build trusting relationships among teams, where people have an opportunity to be involved in decisions that impact their work, where they're proud of the work that they do, so it's not only a matter for pandemics and derechos, it's a matter of what we all need to do all of the time for a lot of different reasons. I think, Joe hit on a lot of the things that I think you hear, kind of any and all of us talking about, just finding those ways to try to help people achieve some balance. Very, very difficult to do right now with the level of volume that we're all seeing. I think I'd harken back to one of my earlier remarks, kind of the same idea. You have to take the supports where people are. We have, as healthcare organizations, we're lucky. We tend to have a fair number of resources. We have our own EAP programs. We have our own counselors. We have chaplains. We have a lot of things that people need. But healthcare workers are notorious in just continuing to keep going, and not taking that break and not taking that time to help themselves. So one of the things that's been helpful to us is getting those resources to our teams. We're of a size we can probably accomplish that, but have the chaplain, have the daily staffing huddle, have the EAP professional in, the break room on the unit, just to kind of facilitate those moments and those conversations, and trying to carve out a little bit of time for people just to talk through what they're experiencing together. I can't know, what it's what it feels like to be an ICU nurse or respiratory care person, but therapist. But they know, so finding that opportunity for them to have some good supported conversation around what they're feeling and experiencing is really key as well.
Absolutely. I wondered if any of our panelists here have any thoughts or ideas on how people sort of outside the healthcare industry, or if there's a way people outside healthcare can help support their healthcare workforce or their public health workforce. This should be noted that they are also burned out. Any frontline worker is burned out. Any thoughts on if people outside this industry can help or do anything to help alleviate that?
I think that it's a really tough question. I mean, I think that a lot of the things that both Joe and Michelle are talking about is important for our staff, at least within our organization. We're failing a lot these days, and it's just for the community to understand that the once in a generation impact to us. I'm not sure whether the pandemic last year was worse or what we're going through right now is worse. It's been a marathon, and so many staff have decided to retire early. So many staff have decided to take traveling jobs. So many folks have decided to do different things with their careers, but the baseline amount of work that's coming in the door remains the same for the remaining staff. And it's really, really a tough situation. And when we see these patients, so many of the staff know that we don't want to turn these patients away. We want to do the care. And so there's this significant moral obligation that folks feel to get the work done, and so much less support that they're getting. And I think at an unprecedented level, it's just kind of unfair. I mean, it's literally the definition of unfair. You've kind of lost control of your environment. You want to do the right thing, but it's not as easy to do the right thing. And it's been not that easy now for 18 months. And so the construct is really difficult. I just think that the community understanding what we're going through as an industry is really important. But I also think that figuring out that this too shall pass, and how we can support each other just as we did during natural disasters and other things, it does matter. I think that folks understanding their loved one that works, or their neighbor that works in the healthcare industry, and what they're going through, and so much of the support isn't going to come from our EAP program. So much of our support is going to come from those people that are the family and friends of our staff, and our patients that come into our organization that have had so much patience with us because they know that we're going through a difficult time as an industry. I think that just that promoting that understanding, and bringing out that best quality in Iowans, to stick together, to work hard, to get through this. I mean, I think that's it. But I mean, I just think promoting that awareness, because I feel like many days. I haven't been inside St. Luke's or even inside Eastern Iowa Health Center recently, or any of these things, but I can just tell you the temperature is just different these days inside of healthcare organizations this many months into the pandemic. And for many of us that have worked in this industry for a long time, it's never felt like this before. It's not like we haven't seen a staffing challenge before or high census before or something, but for it to go on for this long, it's a completely different reality for us, and particularly for our staff. And so I think any sort of community understanding really goes a long way. I remember a staff member telling me, I don't need yard signs. I just need a day off, and I mean, and, it's gotten to that. And I can tell you a year ago, they were so grateful for the yard signs. They were so grateful for the donated masks. They really were, genuinely thrilled, ecstatic for the community support. And now it's moved a bit beyond that. And I think that moving to community understanding, I think is really helpful. But we are lucky, though. I will say that in this community, our employees continue to experience a great deal of kindness from the community. But those are my thoughts, really.
Absolutely. Good thoughts to share with everyone. Kind of diverting a little bit on that topic, but as you said, Suresh, staffing challenges have existed. Iowa has always maybe struggled a bit trying to recruit and retain a workforce. And I think that seems to be continuing, and that seems to have taken on a new tone. So I'm curious, how the pandemic may have changed that challenge, and what new are there going to be new challenges with that as we deal with this pandemic, and as we talk about things like burnout or other challenges the workforce has had to face the past year and a half?
Yeah, I mean, I think there's a bubble part of it. We're in a bubble right now. And then there's a permanent part of it. I mean, the bubble right now is that the nation having a pandemic going on is just increasing healthcare workload across the board. And then a year of delayed care is increasing workload. So for a period of time, probably that'll last for another year, there's a bubble of extra work that we all have to work through, which requires us to have extra staff, which is causing this kind of acute problem that we're dealing with today. Then you have to look at the broad macro trend, which is that in a macro trend across the country, there's going to be healthcare workforce shortage. But if you look at Iowa, and particularly Eastern Iowa, I think because of the quality of the healthcare organizations that exist in Eastern Iowa, we have done really well for healthcare workforce compared to the national trend, because there are so many great places for people to train and start their careers and continue their careers and other things. But we can't lose momentum because of the pandemic. We were on a good trajectory. We need to continue to expand it, continue to partner with our healthcare organizations, our educational organizations at multiple levels, high schools, community colleges, training programs. There was a lot. When I moved to Iowa 3 years ago, I was so thoroughly impressed by how well that infrastructure existed and how it was going. But it needs to continue to grow. And I fear that one of the casualties of the pandemic will be that we somewhat take our eye off that prize. And there are so many different areas of investment. But I would say that this has been one of the strengths of Eastern Iowa. And particularly overall, we're a great healthcare community. Between Cedar Rapids and Iowa City and even the Quad Cities. I mean, there's just great healthcare organizations, great opportunities, great training programs, but we really want to grow them, keep growing them. They should be 10% bigger, every 3-4 years. And that's what we need. And we've got the talent to do it. And I think that we've proven that we can attract folks, but we got to make the investments. And so I would say that this is really a question of whether we want to stick to our guns and continue to make investments in training and workforce so that we can continue to be as good as we've been in the past.
We have a comment here from an attendee who I think actually the comment fits very nicely with some of the points that you've raised, Suresh. This is from Doug Newman. He says, I believe we have extraordinary healthcare quality in the ICR region at surprisingly affordable prices compared to other regions. We should use that more often as a talking point in talent attraction and business attraction, but are there ways to quantify the quality and cost of the region's healthcare so we have something more than anecdotes and testimonies to tout?
Sure. I mean, both UnityPoint and the university work together in an accountable care organization framework, but the metrics that come out of that clearly demonstrate that the cost and quality here, and I'm not just talking about in the UnityPoint and university collaboration, but more broadly, that our results are superior to the national average. And without a doubt, our cost structure is far superior to the national average. And these are clearly demonstrable based on federal data. And so I think that we can certainly show that. I also think, however, that the high quality of systems that we have in the market that work very closely with employers mean that any new employees coming to work for businesses here will have high quality access to healthcare in their local community. And I think that that's also something that we can quantify, that whether whatever end of the corridor you're in, that we have sufficient workforce and capacity and quality associated with that. And so we would love to continue to work with the business community to make that data better understood and more easily available, because it really is a factor. It really is a factor. And Michelle can probably comment on it too. I don't think it's just the quality piece. I think the cost piece of it is also very compelling.
I think that's exactly right. I think, Iowa has health systems in Iowa have been early adopters of accountable care, started from a good place from a cost and quality perspective, yet were prepared and wanted to embrace a deeper focus, working together really to generate value, as Suresh described, that combination of good clinical quality outcomes and lower costs. And it is demonstrable, we're, among, and not only, as he noted, the ACO that we participate in some contracts together in, but others in Iowa as well fare very, very well, in national comparatives, in the metrics that we look at ourselves on there. I think, though, also to Doug's point or question there, I think it is the case that as you work with employers that have national footprints, I've had the experience myself. They will all but say they don't worry very much about healthcare. They don't, they kind of just put forth the plans that are kind of available, and it works as contrasted to how it works for them. And how much of a concern it is for them in other parts of the country. So, again, on kind of that idea of what can we do, kind of coming out of the conference, there might be some of those larger employers with, national footprints that could help us, from their data in illustrating the point that it is healthcare is a good value in this part of the country.
I agree. As you look out the window, we don't see the mountains, and we don't see the ocean. But what we do see every day is an incredible quality of life, and healthcare in general is a cornerstone of that, and it's something that Eastern Iowans not only enjoy and embrace but can count on.
Absolutely. Okay. Maybe kind of diverting a little bit, telehealth has really boomed throughout the pandemic, and that's kind of really seen an innovation in accessing healthcare. Joe, I wanted to talk to you from your perspective in a primary care, oral care, maternal care perspective. How has the introduction of telehealth changed the game for accessing those kind of services and improving the reach for your facility?
Well, it certainly was a game changer. First of all, telehealth is here to stay. That is for sure. We had never, at Eastern Iowa Health Center, we had never done a telehealth visit before March of last year. And it just exploded, and exploded in a good way, because that's if people are afraid to leave their homes because of the pandemic, that still enabled them to access care. One of the most interesting pieces about telehealth, and even from a national and state perspective, is to make sure that we're able to have parity in terms of payment, so that especially from a behavioral health standpoint, if somebody has pretty severe anxiety or depression and they're utilizing their phone, but maybe behind them, behind them in terms of looking at a screen, right? As opposed to just actually being on the phone with a therapist. Maybe their dishes aren't done. Maybe their personal hygiene isn't so great, and so there are lots of reasons, let alone socioeconomic status, about not having a smartphone. But either way, telehealth is really telepsychiatry. We are OB physicians, for example. We did a lot of telehealth with women in the last few weeks of pregnancy, starting last year. And part of it was because so that our own, MD, OBGYN physicians and surgeons were able to keep themselves healthy. And so it worked both ways. It was great for patients, and it was really important that we made sure that our own staff stayed healthy so they could get in those hospitals and deliver those babies.
Absolutely. Okay. Well, in the last 15 minutes, I wanted to ask each of our panelists to share their thoughts on, the point of the panel. What do they think the future of healthcare is? What are big lessons that we're taking away from COVID-19, and where do we see the trajectory of this industry based on not just the innovation that we've seen with telehealth, but some of these other challenges that have sort of been introduced or exacerbated? I'll kind of leave that to whoever wants to take that first, but would love to hear your perspective on that.
Well, I didn't prepare a full essay, but I'll offer a few thoughts here. I think one of the things we haven't talked a lot about necessarily just as of yet is healthcare disparity. So I want to just talk about that a little bit, and I want to talk about it in the context of talent actually as well. I think among the other things that the pandemic reminded of us of or put into more stark light was the differences in health outcomes that people experience based on race and other factors of disparity. Once again, this is one of the arenas where none of us can address those challenges, rectify those long-lasting differences alone. So this is another area that requires public health and health systems. It requires, policy considerations. It requires a whole host of factors to be able to start to address disparity. I always think of that as, first and foremost, the right thing to do for people, but it's the right thing to do for communities as well, because if people are unable to thrive due to health factors or many others, then communities can't thrive. So that would be one piece I would put out. There's a lot of other things to talk about with regard to the future of healthcare. I want to just talk about, workforce too, though, again, related to a certain degree from a diversity point of view. I think a realization for us is that we don't, from a employee perspective, look as much like our community as we could or should today, let alone what we know to be changing in the demographics of our youth and of our communities. And we know that people aren't necessarily choosing us, for healthcare careers. And as Suresh pointed out earlier, we're in a bubble right now where we're extraordinarily busy and kind of behind the eight ball a little bit for reasons that can't really be avoided. But we do have to get back on that that path of developing workforce. And there are so many people that could just really develop some great career pathways working with us if we recognize what the barriers we put in their way are, what the barriers they otherwise face might be, to be able to, perhaps consider us more fully for opportunities in the workforce as well. So just wanted to talk about those couple of issues as well today.
One thing I'd like to add is that we're really focused on health equity. So just to build on that from Michelle's comments, for the first time last year, in the 60,000 visits that we had here at Eastern Iowa Health Center, our outpatient clinics, we had 39 languages spoken, okay? And Spanish wasn't number 2, it was number 3. Somali was number 2. And so it is, that's just a reality. And, we're 77% of the patients that come through our door are at or below 100% of the federal poverty level. So for a family of 4, that's $26,500. And so that's really our niche. I mean, Medicaid is where we thrive. And you know, the thing about federally qualified health centers, and there are 14 in Iowa. Coincidentally, there are also 14 in Hawaii, so it's loosely population based. There are 3,000 across the country with about 9,000 sites. And what our charter is as a nonprofit healthcare organization is, if you can't pay, then we treat you anyway. And so it's really important that we stay at the heart of the safety net where we are, and we treat people where they are, and we meet people where they are, and that we continue to do our part, and to clearly recognize, as Michelle talked about, that while Cedar Rapids is 88% Caucasian, and the state of Iowa is 88% Caucasian, 45% of our patients at East Iowa Health Center are non-white. And so it's very important that we are culturally competent, that we really embrace diversity, equity, inclusion, and just continue to focus on that moving forward.
I would say, first of all, it's never good to go after Michelle and Joe on these kinds of questions because they sound really good, and I completely agree. I would just leave, my big idea would be that Iowa can win. You know, that there's an absolute possibility here that whatever challenges that we face within the healthcare system, that we actually have the strength, the drive, the talent to figure it out. And I would say three things. One, Michelle and Joe both spoke about it. There is no success in the healthcare system unless we get equitable outcomes for everyone, access for everyone. We've talked about some of our underrepresented communities, but I would say just as importantly are our rural communities, where there are great differences based on what zip code you were born in or you live in. And so I think that that's certainly one pillar of us winning. And I think that if we all collaborate together and make the right kinds of investments in both the public and private sector, we can make a difference. Two is workforce. We've got to be a destination for healthcare workforce from around the country, because this is a community that cares about its health systems, cares about its healthcare providers. We've long admired the work that Joe's team does at the Eastern Iowa Health Center, and we know that they do amazing work. And similarly, everyone knows the tremendous reputation that Michelle's team has in Cedar Rapids. And you know, these are great centers, but they can only be great centers if they continue to get great workforce. And the university does worry a little bit more about physician workforce and trying to make sure that more of our graduates choose to practice with Joe and with Michelle and with others in the state of Iowa, because I think that's really important. And if we can continue to win the workforce game, I think that our healthcare system will be really, really strong. And then I think the third piece that we want to make sure that we continue to do is innovate. There is no reason that you need mountains or oceans outside your window to do innovative healthcare delivery. And you know, a lot of that energy exists here in Iowa, and we just need to connect the dots, whether it's on telehealth, whether it is on more consumer-driven offerings and more convenient settings. Because at the end of the day, it's about access. I mean, it's about convenience. It's about figuring out ways to get care to the lowest cost settings. And I think all of that is possible in Iowa. We don't need to go on a field trip to somewhere else to figure it out. A lot of the organizations in this state have the capability to do that. And so I really think the big idea is why not Iowa? You know, I mean, I think these healthcare challenges exist everywhere. But who's best suited to handle them? And I'm very optimistic about the home team here.
Absolutely. So we just have a little under 10 minutes left. So I wanted to be sure to leave some time for some audience questions. So audience members, if you have any questions for our panelists, please go ahead and populate them in the chat. And as we wait for more, I will go to this first one that we have. John Hale asks, healthcare and long-term care are often viewed as separate and distinct, working in their own silos and shifting Iowans from setting to setting without holistic approach to individual life. What can or is being done to bring a more collaborative approach to caring for and serving Iowans?
No, that's a really great question. I think it's a hard question as well. And you talk about Iowa. It's an important one here, both from the perspective of rural populations and aging populations as well. A couple of things that I think that I would note. One of them, we've talked a little bit about accountable care, without getting into a sort of lengthy description about, kind of how all that works. It is at its essence meant for us collectively as healthcare providers to be more supportive of people, not only in episodes of care, but over a more longitudinal period of time. So those achievements of quality and cost generating value aren't meant to be, what happens next week or this year, but over a broader period of time. So I think, in fact, some of the models, accountable care, value-based care, are pressing us as healthcare organizations to be in better coordination across all parts of the continuum. In no way do we have that mastered as of yet, but I can cite, examples of things that we do much differently today in supporting transitions from care setting to care settings, in our outlook about how to make sure people are in the level of care that's most equipped to serve their needs holistically, and that might very often be home. So what are those additive resources that can surround people at home? That is where they want to be, and they can, ultimately thrive there for where they are in their lives. So, I feel like some of the value-based care focus does help us move in that direction, but there's definitely a long road to travel there to do our best to serve.
I agree. It takes all of us to improve population health, and coming from a lot of different angles, and it certainly takes a village to take care of the entire population.
Absolutely. Suresh, do you have any final thoughts to share on that question?
No, I think that the key thing I'll just say is that as we evolve the healthcare system, I think that we continue to ask ourselves, whose patient is it anyway? And I think that why we fail is quite often we only take the view of every one of us when we see them say, no, that's our patient. When in fact, we're just one constellation in the patient, and especially at the university, we're not the majority of the care that usually patients are. And so I think it's going to require a different view that puts the patient at the center instead of our own systems at the center. And that's kind of hard, as Michelle mentioned. But that doesn't mean that's not right. And so that I think we're all committed to kind of moving in that direction, because as Joe said, we recognize it takes a village. We just need to figure out what our seats at the table are. And I think that over time we can do that. And as Michelle pointed out, with the aging of the population, I don't think this is optional. I think it'll be a requirement of what we need to do. So I think that would be it.
Absolutely. Okay, I see no other attendee questions in the chat, so I think that is it for us today then, and this panel. I want to thank our audience for joining us today and joining us for this conference. Hopefully you found something insightful or helpful either in this panel or other panels to carry forward with actionable steps for solutions. And of course, a huge thank you to our panelists, Joe and Michelle Suresh, for joining us today and for sharing their insights. It's always much appreciated to have you guys here and sharing our expertise. So thank you.
Thanks, Michaela.
Thanks for having me.
Thank you. And thank you again for everyone for attending.